All right, reasons for an amputation. Usually it has to do with perfusion or an oxygen supply or inadequate nutrition. You see it almost always in diabetic patients. A lot of times if they're diabetic and they wound their foot, they don't feel it. And then it gets infected, gangrene sets in. They can sometimes become septic. Also, amputations are necessary if they have maybe bone cancer and a tumor, or trauma or a burn that is incredibly severe. You also have to make sure that if they're ischemic from PVD, that maybe it can be reduced with other maybe grafts or that kind of thing. And again, I say you have to make sure. That's not your job. But there are options with bypass grafts and that sort of thing. Diabetes, anybody with PVD has a certain higher risk for the chance for amputation. Biggest complications of amputations: post-op hemorrhage, pain, both surgical and phantom pain. Phantom pain is real. They will tell you that their toe hurts and they don't have a toe anymore. And if you massage where that toe was, the pain will go away. Very, very odd, but very, very real. Another issue you're going to have is disturbed body image. And through several of the videos you're going to be watching, I'm going to be talking about the stages of grief. And when you're talking about grief, you don't have to be talking about a person who died. Grief happens when you have a loss. And there are usually 5 stages to grief. The first one is denial, which is, that won't happen to me. My diabetes wasn't that bad. My foot that was hanging off and smelling horrible wasn't that bad. The second one is anger. They're not going to have a leg anymore. They're not going to be able to be as mobile. Third stage is bargaining, and that's God save my leg, and if you save my leg, I'll become a missionary. Fourth stage is depression. So whatever loss they have endured, they become depressed instead of dealing with it. And then finally, the last stage is acceptance, where they accept what's happened to their body, whatever loss they've encountered, they accept. These 5 stages, that's kind of the 1, 2, 3, 4, 5 order, but they can happen in any order. Just remember that there are 5, and that's kind of the typical order for them. But this patient might be really angry and belligerent, and they are going to take it out on you. So you make sure that you use therapeutic communication. And in this situation, the best therapeutic communication is to smile and hold their hand and let them get their anger out. Don't take it personally. Don't leave the patient. Don't argue with the patient. Just be supportive. And that is a huge part of our job. As you're studying this, and I've told you this before many, many times, as you're studying these units, we always get so focused on the pathology and the actions of the medications, and quite often that's not our job at all. Our job is supporting the patient, and in this situation, that's what you'll be doing. When the patient comes back from the OR, they'll have ACE bandages to prevent bleeding, and that'll be like a pressure bandage. You want to look for signs and symptoms of bleeding, signs and symptoms of infection, and again, handle the therapeutic issues as best you can. Here are some nursing considerations. It is extremely imperative that if somebody has a above the knee or directly below the knee amputation, that you when they're in bed, they're either laying on their belly, or if they're laying supine, make sure that a pillow or something is over the stump so that it lays flat. There's no weight to hold the leg down. So you can see here, if it doesn't have the weight of the foot, the leg won't lay flat. And if we don't force the leg to lay flat, then it's going to pop up, and then the musculature will eventually form that way. So it's very, very important that we keep that stump down so it heals right. You don't elevate a stump ever because, again, then it won't heal appropriately. There will be a pressure dressing, again with an elastic wrap. We want to watch their pain level, and ice is their best friend. Do not hang the stump over the edge of the bed. Sit in a wheelchair with the stump flexed. Place a pillow under the hip, knee, or back. And again, all of these things on this slide have to do with the healing of the stump so that it lays in the appropriate way. Another thing that you want to know is how to wrap a stump. If you haven't done it before and you get on the floor and there is one that you can do or you're learning how to do it, make sure that you tell the nurse that you're working with that you haven't done it before, because it's very important that the stump be wrapped properly and very rounded, and that the ACE bandages are put on right. And the reason is you want the stump to heal so that the patient can eventually have a prosthetic device. So that's all we have for amputations, and now we're going to move to spinal cord disorders. There are a lot, but mostly I'm going to talk about herniated discs because that's what you're going to see in your first year of practice. If you decide to work on a neuro floor, then you're going to deal with disectomies, you'll deal with spinal cord fusion, maybe spinal cord injuries, all that kind of stuff. But in general practice, caring for aging people, you probably will see very few spinal issues beyond the normal herniated disc. For those of you that were with me at the nursing care center, you saw what happens when someone has a disc that bulges, and the biggest issue, of course, is pain. So we have to help this patient not only heal, but control their pain appropriately. It's a very common occurrence. The disc is like a soft, squishy, almost fluid-filled pillow between each of the spinal vertebrae, and that disc can tear, and then the soft, it's almost like a gel on the inside, can leak out, and that's when it's herniated. And when that disc is herniated and the gelatin comes out, then one disc compresses on nerves and on the next disc potentially, and that's where the pain comes from. Usually happens from falls, lifting heavy objects, motor vehicle accidents. Sometimes it happens just because of stress. Here's a good picture, and you might want to blow it up on your computer. And here's a great video. Hopefully it's still available on the pathology of a herniated disc. Again, if you see a video throughout these podcasts, make sure you stop and watch the video. The first thing you're going to see if there is a herniated disc, it depends on where it is. If it's in the cervical region of the spinal column, you'll see spasms in the neck, decreased range of motion in the arms. You'll have pain on both sides of the body, numbness and tingling, and weakness or atrophy eventually can happen. If it's on the lumbar section, and this is the more normal or more prevalently seen herniated disc, is the lumbar, so that's the lower part of the back. Pain goes down one leg. There could be paresthesia, so tingling, weakness, limpness on the affected legs, and muscle spasms. It can affect both legs, and quite often in a bulging disc, it's classic that it's only one leg, and herniation can be two, but sometimes one. It is diagnosed with a CT, an MRI, or a myelogram. You cannot diagnose a herniated disc with an X-ray because you can't see soft tissue on an X-ray, so they have to do more than that. treatment is medical management, and there's all kinds of different treatments. Ultrasound therapy, heat, ice and deep massage, a TENS unit. This is great because it's non-pharmacological. When the patient is up to it, they will prescribe strengthening exercises, and the exercises are usually abdominal, because if you strengthen your abdomen, then your back will, the abdomen can take some of the hit for the strength, and then the patient will be educated on proper body mechanics. You want to keep this patient off of narcs as best you can, and one thing they do almost immediately now, which is a newer therapy, is steroid therapy to bring the inflammation down. And some docs will say chiropractic care, some will say no chiropractic care, and that's perfectly the belief of the patient. Personally, I'm a firm believer and advocate for chiropractic care because it is non-invasive. But there are other healthcare professionals that would completely disagree with me on that. So now I'm going to skip slide 26 through slide 37. So I'm skipping them for this exercise because the information that you can glean off of these slides is information that you can read, as well as some of the slides have notes at the bottom of them. So I'm not going to podcast all of the information for the slides in between this slide, which is 26, and then I want you to skip to slide number 38, and we will pick up there talking about soft bone and soft tissue disorders. In between slides, I really want to encourage you to read the information, to make notes from your textbook on them. But like I said, there's not much I need to add that's not already written on the slide, and you can do that on your own time. I want to talk about carpal tunnel syndrome. You will see this a lot. And carpal tunnel syndrome usually happens to people who have some sort of job where they do repetitive motion. Back in the day when I was going to nursing school, I delivered newspapers in the middle of the night. And I did that for 17 months. And at about month 11, my left wrist started hurting from tossing the papers out. And so I got some braces and did some things and was able to ward off true carpal tunnel, but that was certainly the start of it. People who work on computers all the time and hold their hands in the same position quite often get carpal tunnel. Signs and symptoms are hand, wrist, pain and numbness, tingling. At night, it's amazing how bad they tingle and hurt. Sometimes there's fine motor deficits and muscle weakness between the thumb and the opposing joints. It's diagnosed on signs and symptoms, and a positive failing sign, which is numbness when the wrist is flexed, and then they can do a procedure called an EMG, and that'll look for nerve deficiencies in nerve stimulation. Treatment starts with carpal tunnel with a simple wrist splint that you can buy at CVS or something. The patient should be taught to not do the same repetitive motion. Try to find a different position, different way to move their hand. You can give NSAIDs. They might use a cortisone injection. Sometimes they'll use aspirin, but aspirin is not used very often anymore for pain relief just because of all the other things that aspirin can do. If none of those treatments work, then surgery is the best option. And they'll go in and they will move that nerve. Sometimes they cauterize it and to stop the pain. So on the next video, this is video 2, so on our next one we're going to start talking about osteoporosis.